very enthusiastic about I see your work, and it's wonderful. So, looking forward to your presentations. So, Dr. Virk, is recently appointed here as assistant professor of surgery. Okay, who will present us a very interesting case. Okay.
It's not a case presentation. It's a talk about splanchnic artery aneurysms. Good afternoon, everyone. I'll present some literature about the visceral artery aneurysms. This was, if you look at the history, this was first described in European literature more than 200 years ago about the management of the aneurysms. Dr. DeBakey in 1953 first published the first successful treatment of SMA aneurysm. This was an open procedure. And before that, there are only few case reports after some post-mortem discovery of the aneurysm. In general population, the estimation incidence is 0.1 to 2%. Looking at the anatomical location of these aneurysms, the splenic artery aneurysm, 60% of patients, hepatic 20%, and SMA is 5.5%, and the celiac is 4%, so way less. So most importantly is the splenic artery, that's 60%, and then comes the hepatic, and then comes the SMA. So what are the causes of, so the aneurysms can be divided in two parts. One is the true aneurysms consisting of all the three vessel walls, and one is the pseudoaneurysm. So atherosclerosis, medial degeneration, probably the main causes. Then collagen vascular disease, Ehlers-Danlos syndrome, and fibromuscular dysplasia causes aneurysms. And splenic artery aneurysm, especially in like multiparity women, association with the portal hypertension and post-transplant patients are coming up for the splenic artery aneurysms. Causes of pseudoaneurysms include infectious, can be from vasculitis, from surgical procedures, hepatobiliary procedures, endoscopic interventions, and from trauma. So looking at like how the way they present is 22% of these patients they present as clinical emergencies, and including 8.5% whose splenic arteries they result in death from the rupture. And if these aneurysm rupture and there is a hemodynamically instability, circulatory collapse, then the preoperative mortality goes way high up, like 20 to 70%. So general guidelines, just looking at the splanchnic artery aneurysms, if they are less than 2 centimeters in size, asymptomatic, and they have not shown any growth, and they can be observed safely with the CL imaging. But depending upon which splanchnic artery aneurysm you're looking at, which study you're looking at. But regardless, in particular one group, that's the women who are either pregnant or childbearing age, regardless of the size, they need to be treated. There's a high incidence of rupture and fetal loss. So looking at the repairs, open surgical repair can be done, aneurysmectomy can be done, bypass grafting can be done, aneurysmorrhaphy, just repairing the aneurysm, and just ligation depending upon the distal blood flow or any collaterals. So now looking at just the celiac artery aneurysm, we already looked at the anatomical location of the celiac artery aneurysms. Only 4% of the people in total of all splenic artery aneurysm, they have celiac artery aneurysm. There are almost like 100 cases reported in the literature so far, and 40% of them concurrently found with other splanchnic artery aneurysms. And so you have to look, you have to be careful, is there any other aneurysm whenever you see a scan with a celiac artery aneurysm, make sure there's no other aneurysm elsewhere. And with abdominal aortic aneurysms, the chance of like 20% in those cases. So you have to look for infrarenal abdominal aortic aneurysm, any other thoracic aneurysm, or any other splanchnic artery aneurysm. So again, the causes we discussed earlier for the splanchnic artery aneurysm is atherosclerosis. The main cause for celiac artery aneurysm is atherosclerosis. Infectious etiologies, 20% of the cases. Mostly they're found in men, and the average age is 56 years of age. So this is a literature review that looked at 108 celiac artery aneurysms. So interestingly, before 1950, because the prevalence of syphilis was very high at that time, so 40% were infectious and usually were from syphilis. Nowadays, no cases have been recently reported from syphilis. 7% were traumatic, and 52% they were not able to determine the cause of the celiac artery aneurysm. Most of these were also symptomatic, came with abdominal pain. Majority presented with rupture, hemodynamically instability, and most of the patients were diagnosed at postpartum examination after rupture and death. So presentation-wise, historically, the mortality after rupture has been reported as 100%, but nowadays with like advanced care, pre-hospital care, the mortality has gone down. The rate of rupture is 10 to 20%, and the mortality is decreased to 50%. Usually they present with some vague colicky abdominal pain, can present with intestinal angina kind of symptoms. Some of the patients, they also present with biliary obstruction with GI bleeding, jaundice, hemophilia. This is the Mayo Clinic series. They looked at, given the reported mortality rates associated with rupture of 50%, so they tried to look at it, whether these patients with the celiac artery aneurysm, whether they can safely monitor them, or if they don't do any intervention on them. So this is so far the largest case series which they looked at it, just observing the patients and not doing any intervention. So they have reported outcomes of 18 celiac artery aneurysms, and in 8 patients they were considered very high risk for intervention. So they followed these patients serially, and there's only one rupture on those 8 patients, and that was in 2.5 centimeters, and it was 5 years after initial presentation. So according to this series, if you look at it, you can safely observe if the size is less than 2.5 centimeters. But what's the goal of the treatment? The goal of the treatment is excluding the aneurysm sac and preserving the distal blood flow. If you're not able to achieve the above 2, then you go for the third one, that's you occlude the blood flow to the aneurysm. Looking at the options of open surgical versus endovascular approach, always you look at every patient is different. So clinically, you look at the patient site where exactly in the vascular bed the aneurysm is, location within the affected artery, proximal versus distal, or whether there is any branch involvement or not. Any associated risk factors, the patient is good open surgical candidate, or patient cannot be put to sleep. So these are the things you need to look at, and whether you have local expertise to perform a good endovascular repair of these aneurysms. For visceral artery aneurysms and visceral artery pseudoaneurysm that affecting the vessel that supplies an end organ, and if they have multiple sources of flow, like collateral, these can be ligated surgically or can be coiled or embolized percutaneously. So you have to look at the collateral vasculature before you plan for any intervention, either it's open or endovascular. And if you compare, like what are the benefits of open procedure over endovascular? So the series have, a couple of series have been looking at this, and they say the advantage is the durability of the open procedure is more. There's no need for further follow-up studies, and the mortality is as low as 0.5% in elective repairs. So what are the advantages of the endovascular approach? So there's obviously reduced invasiveness, less post-op pain, less hospital stay, decreased wound complications, quality of life is improved in the short term though. So the Cleveland Clinic experience, there was an endovascular treatment in 48 patients. The mean age of patients was 58 years. As we discussed before, they're more common in men, 60% men. 20 splanchnic artery aneurysms and 28 pseudoaneurysms. So they were able to achieve technical success in 98% of the procedures. This was done in 20 splanchnic artery, 12 hepatic. So this also tells us the first diagram we looked at, splanchnic is number 1, then hepatic number 2. So the same way they were able to achieve technical success in the splanchnic artery. They used coil embolization in 96% of the cases. Glue butyl 2-cyanoacrylate was used selectively in 19% of the cases. Their 30-day mortality was 8.3%. They were able to completely exclude the aneurysm sac in 97% of the patients with the follow-up imaging. So they had very good results with the small series, and they did not have any access-related complication, no big access-related complication. And 3 patients developed post-embolization syndrome with fever and splenic infarct after splenic artery embolization. So this is an example of approximately 2 centimeters splenic artery aneurysm. This is coiling of the outflow tract, inflow tract, and coiling of the aneurysm sac. So coiling is the most used method in all of the series which I reviewed. Second is placement of a covered stent and excluding the aneurysm. The covered stent excludes the aneurysm. Nowadays, experimenting with the flow diverting stents. Mostly these were used in the cerebral circulation, but one of the study in Italy, they have looked at 19 splenic artery aneurysm patients, and they have very good results from freedom from rupture, patency of the stents and the branch vessels, and sac shrinkage, and very low morbidity and mortality. We'll quickly discuss a paper from Society of Clinical Vascular Surgery. This was published in Journal of Vascular Surgery. This is a paper from Mayo Clinic. This is the largest series which have looked at the minimal invasive management of visceral artery aneurysm and pseudoaneurysm. This was published in 2010. So the objective of this study was they reviewed a 10-year experience with minimal invasive management of visceral artery aneurysms. So they reviewed their charts from June 1999 to June 2009. So as we discussed earlier, the splenic artery aneurysm was the highest incidence. So true aneurysm in splenic artery or 63% of the patients, pseudoaneurysm in 37% of the patients. If you look at the celiac artery aneurysm, true aneurysm in this series, they did not have anyone, and then pseudoaneurysm were 4 patients. So indications for intervention by location was mostly by the size, greater than 2 centimeters, and then hepatic, they went by greater than 2.5 centimeters. The other main indication for intervention was bleeding. They have one patient in celiac artery with bleeding, which they did intervention by endovascular means. So this is interesting. The techniques they employed for aneurysm management is most of the patients were managed with coiling, 162, and covered stent was placed in 10, and then gel foam injection, then plug deployment. Two of the patients, they had percutaneous coiling also with ultrasound guided or CT guided. So the results in this series were so total 185 aneurysms in 176 patients they were able to identify. So as we discussed earlier, more incidence in men. So the same thing here, 56% for men, 44% were women. The mean age diagnosis was 58 years. And 15 aneurysms, that is 8% in this case series, was attributed to connective tissue disorders, Ehlers-Danlos syndrome, fibromuscular dysplasia, or polyarteritis nodosa, this necrotizing vasculitis causing splanchnic artery aneurysm. In 38 patients, they were not able to identify the cause, and they thought maybe it's from previous interventions. Looking at the other patients, they were able to identify 14 patients with aneurysm who had liver transplants before. So it's always important to get a good history from the patients or had any other procedures before, like any biliary procedures or any percutaneous liver biopsy that can attribute the cause of the splenic artery. And then pseudoaneurysm, we discussed trauma. We were able to count 11 pseudoaneurysms from trauma, and 4 they had to treat for acute bleeding in this. From a technical standpoint, they used femoral artery access in 148 patients, and the brachial artery was used in 28 patients. No big access related complications. They had some pain and hematoma in 12 of the patients. That's 6.8% in this case series, and but other than that, no access related complication that required re-intervention. So they were able to treat same as we looked at the Cleveland Clinic series, the same Mayo Clinic series here also. They were able to achieve technical success in 98% of the aneurysm. They repeated the imaging within 30 days, and they were able to identify the persistent flow in 5 cases, and that subsequent underwent a re-intervention. The follow-up was not very effectively described in this case series. They did report 30-day period, they had 11 deaths, and overall 30-day mortality was 6.2%. But some of the patients, they thought they had like cardiac complications, any other disease rather than aneurysms, but the true aneurysm-related 30-day mortality was 3.4%. So as I said, the follow-up on this case series is not effectively described in the paper. The repeat imaging within the first 30 days is available on 150 patients, and the long-term follow-up mean was 524 days. In 8 cases, they noticed that the liver infarction was there post-aneurysm treatment, but there were no re-intervention was needed on those cases as well. So looking at this series and comparing it with the previous series and historical data, I guess the imaging techniques have evolved. They're more enhanced now. More intervention is the biliary tree, organ transplantation, and a lot of trauma and trauma management, iatrogenic. So the incidence of visceral artery aneurysm is on the increasing side now. So the conclusion from this series was this represents one of the largest series of management of visceral artery aneurysm, particularly endovascular management with a long-term follow-up. But as I discussed earlier, we're going to see more and more of these aneurysms in the coming days. Thank you.
Any questions for Virk? Comments?
It's very good reviewing of pretty much everything. So I just don't know, I know you guys probably know. The reason you see more coiling than cover stent, I think more recently, cover stent procedures getting more and more. But this chart, this aneurysms, usually, back to 10 to 15 years ago. So back to those days, we didn't have cover stent yet. That's why you got more percentage of coil embolization. So ideally, we want to keep the vessel open for stenting. For renal or SMA, of course, we want to keep those vessels patent. But even for renal artery, we want to have this vessel preserved. Otherwise, you would need to give a patient, antibiotics, the vaccine, all this, watch for infection for the rest of the life. So we prefer that. I don't know how they use a glue to kind of treat those. I mean, that's kind of sounds like.
The thing is, traditionally, what we have seen in visceral aneurysms, and away from the celiac or SMA, we see mostly the aneurysms of the phrenic artery due to pancreatitis, and those recoil. Or hepatic artery, or any of the arteries of the branch of the celiac axis that may be affected by pancreatitis. The hepatic artery is one thing. The second in frequency after the phrenic arteries of the hepatic artery, and the gastroduodenal. And they usually are managed with embolization. We have seen post-colonoscopic cholecystectomy, a pseudoaneurysm, 9 years after the surgery. The patient presented with hemophilia, rupture in the biliary tree. And we resolved that with embolization and direct, injection into the aneurysm. That's interesting. But otherwise, we have not dealt with actually all the vascular stuff. Peripheral vascular, you do.
Yeah. Actually, I wrote a chapter for peripheral vascular intervention, which is coming on about about the visceral artery intervention, including aneurysms, you have different techniques you can use. Like we mentioned, you can do coil. Now we have like a detachable coil, so like the interlock. So you can put a coil in your tag, the sac, and then you happy you release, and the coil is not going to go anywhere, just stay inside the sac. Let's make this procedure much more safer than before. And also you can do, I'm sure you guys know, you do a double wire technique, and one in the sac and one just cross over. Yeah. You deploy the bare metal stand first, and then you coil the tag. Then the coils will stuck in there. That's another technique, right? And the cover stand obviously. So, and also surgically you can do laparoscopic, like a splanchnic aneurysm. They can ligate with the laparoscopic technique, all different procedures. And the previous we have to do a whole thing. And it's a big sort of mortality rate.
How do you treat, I'm sorry to interrupt, but a question on mycotic aneurysms. How do you treat mycotic aneurysms? Always open, endovascular?
Mycotic, usually, it all depends on what cause that. Usually you need, especially, like you have necrotic pancreatitis, you need to go in here to degrade the necrotic pancreatic tissue anyway. So, and if the case, you probably have to, remove the spleen, which is like to do direct repair, you have to obviously have to use a vein graft. So you don't want to do a cover stand, and it would be infected, and that would be much worse if you go back in to remove this infected graft. So you can more extended the graft to the proximal. It's a very difficult to control.
Thank you.
All right. Any other questions? First, I do apologize for this. We're supposed to have lunch here, and for multiple reasons, because I was out of country for 2 weeks. Just came back. Dr. Tan left. Dr. Virk just started. I have not completely kind of passed this on him yet, and we didn't have our, secretary here. I remember I told her, but I'm sorry. I think that's my fault. Next time I treat her double burn. Okay, so I like to. So my topic today is like left subclavian artery revascularization when we do TEVAR. But we have a little more time. I like to, I'm going to give a talks at the VIS meeting. I don't know if you probably know VIS meeting, which is the largest endovascular meeting in the world. It's always in New York City. Next week will be the 44th annual meeting. Yeah. So let's. I have a video presentation here for fEVAR for suprarenal aortic aneurysm. So I won't take too long. Let's see if we can play here.
Like your piano.
Okay, so this is a 63 years old gentleman, 5.6 centimeters, suprarenal aneurysm. How about history of COPD and coronary disease? As you can see, aneurysm all the way up to SMA. So previous we have to do an open with very high morbidity mortality. We decided to do percutaneous fenestrated EVAR with the C-tag. The mean step, you have to do a very accurate clock position where your branches come from, centerline measurement, do fenestration, and repack that back in there. Because I only have 5 minutes for that, that's why you can have short. Here you do like a 12 o'clock, marking, and then based on at the which clock position, and also how far from the edge you mark the branch, and then make a fenestration. and reinforced with a snare wire. So for two reasons, you make the hole, strong, and also you can see it under floral, and you know where the holes exactly. You have to match up all these branches. One vessel fenestration is easy, you can rotate in there, but if 2 or 3, you have to match them exactly where the branches are. Otherwise, you have one renal artery covered or SMA. So that's a 3 vessel. And we used to use another sheet, but now we use like this constraint cover, which the yellow thing comes with. We fenestrate the pre-wire with 014, and then we put the pulling suture. This will help us to kind of push it back into the sheet, as you can see. Reconstrain this. This part is pretty tough, so you have to kind of push back in. And then this is 18 French. So what we use, okay, we got the arm access from the right arm, and then we got the femoral access with 22 French sheet. And then we orientate the graft. You need to know, your fenestration is anterior or posterior. If you deploy it posteriorly, you totally screw. So you have to make sure. That's very, very crucial. And then you push this up. And then you see how many wires in here. Sometimes I have to move around and find out which wire I'm, working on. All right, you open the contralateral gate, do angio to find out the branches. Now we select the red renal. You do an angiogram, from the set hole, and a cannulate, and a switch, conform and switch to super stiff wire. And this is the left renal through the hole, and conform it as well, and SMA. So now you got all branches. It looks like easier, but take a time. Okay. Now we put a cover stent, and I know before you do that, you pre-dilate the main graft. Otherwise, you will push your side branch stent graft out. Then we stent SMA, and then the left renal artery. And the right renal. It's all act as cover stent. And then, okay, we do an angiogram to make sure all the branches are patent. And then we finish up with the extensions to seal into the common iliacs. It's like it's a post-deployment dilatation. This completion angiogram, you see the aneurysms completely sealed, all the branches are well patent. That's a follow-up CT angiogram with 3D reconstruction. Okay. And no endo leak. Yep, that's about it. So
I want to tell you something for me. This is wonderful, and we are very fortunate to have people like Dr. Zhang and Dr. Virk here that do this. I see some of the studies that operations have performed. They are fantastic. The alternative was a disaster in the past. All the things done manually, the work required a lot of skills and everything. And all the time we're fraught with a lot of complications, thrombosis and everything. And moreover, what you do in the chest, you're trying to operate a ruptured thoracic aneurysm. It's devastating for the patient. And today, with these techniques, you can really, your results are super much better. We are really very fortunate to have you guys here, and we can learn a lot from that.
Thank you very much.
How long does it take for?
So I was going to ask, how long
how long does the procedure take? some procedure can take a long, at the very beginning you have a learning curve. So we did a protocol almost probably 10 hours. But for this procedure actually, so from the fenestration, you know, you need probably 1 or 1.5 hours on that table to modify this graph. We finished this case probably within 5-6 hours. But if you go open, you probably take a lot shorter than that. So you have to kind of reconstruct all of the visceral vessels. You have to do bypass to the SMA, to bilateral renals, and reconstruct the infrarenal aorta with that rate around probably 10%, for suprarenal or thoracoabdominal completion rate 30%, something like that. So we have done this, and we have not had any bad perioperative, you know, with suprarenal or thoracoabdominal.
This is formidable.
Yeah.
Fantastic.
How much fluoro time do you think?
Well, it can be long. So we had one patient had a radiation burn. You know, radiation burn, it's hard to predict. Some patient you can have like a 1 hour radiation, and you can have a radiation burn. But some patient we have like 5-6 hours, so you don't have anything. But average for this, I cannot remember. Probably you know, I think maybe 2 hours or so. I think. It takes time, especially for thoracoabdominal. You would do a 4-vessel fenestration. I mean, it's not a good thing for us, but I think it's a good thing for patients. Actually, so we are the team, the first team in the United States to use this type of graft to do these procedures. Cook Dennis have graft, but it's not available here. And there's no graft available in the world at this point to treat thoracoabdominal. And we use this to treat. And we've got all 4 vessels fenestrated, and we covered from you know, left subclavian all the way down to the iliac arteries.
It's fantastic.
I mean,
Fantastic.
it's a very, very complex case. So that's what I said. Every time after that, my white blood cell count dropped to like a lower normal. Okay, let's see another one. Any questions?
I don't know if you want to. You know, we can leave it for another opportunity. You know, if you want to. You know.
So that's another talk I'm going to give at the meeting. Actually, that's on the schedule. Talk about left subclavian artery percutaneous in-situ fenestration during TEVAR. All right, so up to 50% of TEVARs have a planned left subclavian artery coverage. So if that's for all, including dissections and aneurysms. But if you do dissection, the rate is probably even higher because the majority of the dissection retrogradely to the left subclavian artery. So now the question is, like this patient, you got the arch aneurysm, okay? You need to cover it to seal the completion, to completely seal this. And you have to cover left subclavian artery like this. Okay, now look at this imaging. So there's no flow in the left subclavian artery. Now it raises the question, do we need to revascularize this left subclavian artery or not? We do not have to, except the patient has dilemma. So with cabbage, and they use left internal membrane to do a bypass. So otherwise, you can do selectively. But if you don't do, let's see what data show. To compare with revascularization and revascularization. If you don't do left subclavian artery revascularization, that's a paper just published last year. Now you can see stroke rate is 25%, in the group without the revascularization, but it's only less than 2% in revascularization. And the upper extremity ischemia in unrevascularized group is 15%, but 0 in the revascularized patient. Now, of course, you have a flow in here, and it's significant. I also see this meta-analysis. Almost all these studies favors left subclavian artery revascularization based on perioperative stroke rate, spinal cord ischemia paraplegia, and perioperative mortalities. Now, what about the guideline? That's the SBS, Society for Vascular Surgery, gave us a guideline. It recommends routine revascularization in patients who need coverage of left subclavian artery to extended proximal landing zone during selective TEVARs. So now the question is, how do we do it? We know we need to do it, and how can we do it? So of course we can do hybrid procedure, and you can cut the neck open and do a bypass between left subclavian artery and left common carotid artery. However, this is not a very benign procedure. You see a lot of important structures here. It's like phrenic nerve, cervical plaque, nerve plaques, and veins, arteries, and thoracic duct. This is a dangerous area. So if you do open, you can have probably 13% complication rate. So you can do a chimney, which means you do have to fenestrate. You just put a small stent inside either carotid artery or left subclavian artery with the chimney or snorkel procedure. However, this type of procedure is associated with the type 1 endoleak, 11%, and type 1B or type 1A, which means from proximal, right? That's 11%, and type 1B from distal, that's 8%. Ideally, we want to see this. We want to see the big thoracic stent graft wrap around a little bit around about the branch of stent graft. But the reality is the majority of patients, you have a gutter leak. They are stent, right? That's a metal in there. They cannot just go around it. So have gutter leaks very common. And that's why you have these relatively high leaks. And also, the big stent graft and small stent graft compete the space. To achieve complete sealing, we already oversized the big endo graft for thoracic aorta. And to compete this space, the big stent graft usually can cause narrowing, total occlusion, or small graft. So those stent grafts are under investigation, but they're still not available yet, have not been approved by FDA. So then what we do? So our patient cannot wait. We have to treat those patients. Somebody used direct needle puncture. You guys are probably, I don't know if you're familiar with this needle, probably do liver biopsy or something they use this. But they still need a cut incision above the clavicle. It's invasive, and we use a laser percutaneously, and without making incisions. You just puncture brachial artery. Okay, let's see. You can see that. I don't know what this one is. Oh, and this rotate for some reason. You can see this come down to, and then that's after. That's we did this test, use a demo. That's the laser make a hole like this. And then once you got into it, and you can pass a wire and they use a cutting balloon and then sequentially dilate and then deploy a cover stent to open. But when you do this, I always recommend you to do different angles and angles to look at the anatomy. So for example, this patient, if you just do a LAO, which is a normal view, we do the arch branching endovascular procedures, and you don't see significant difference. But if you do a RAO, and you can see the tortuosity with a big angle. If you try to use a laser to kind of puncture through the stent graft, it may make a hole on this left subclavian artery. So you always try to have this past the angle or kink to have a laser catheter directly contact the major graft, and then you can make the hole to do a fenestration. That's what ideally we want. However, clinically, we often see like a type 2 or 3 arch with a sharp angle between the left subclavian artery and the arch. So if we have this anatomy, then laser probably not a good thing to do. So we first published this paper to use re-entry devices for the fenestration. We either use all-back or off-road based on anatomy and the angle. So if you have this sharp angle on the left, as you can see, and we prefer to use off-road because the needle comes out from the side, and when the needle come out, you pretty much still can have almost 90-degree angle, and it will be easier to puncture through. But if you have angle between the left subclavian artery and the aortic arch is near 90 degrees, then you can use off-road and straight down to puncture through. So once you go through, then that will be easier. Oh, I don't know what happened here. Once you go through, and you just need to switch over. This is 014 system. You sequentially dilate with cutting balloon and then cover stent. Now here is a case I'd like to share with you. It's acute type B aortic dissection, and this is what we did. We covered the left subclavian artery, and the angio shows, it's no significant leak, but we don't have flow go anywhere any grade. So we did a fenestration with this patient. I think it's a red angle. We use off-road crossover and put a cover stent in here. Here's another patient, and this angle is like a sharp. We use the all-back and then put a cover stent in there. After the deployment, you can use a bigger stent to dilate the inside portion and make it like a flared, and that won't move distally and also decrease the chance of type 3 no leak. Here is the patient, 9.6 arch aneurysm, and transferred from outside hospital to consult for the second opinion, and the patient decided to stay with us. And here is a patient. We need to cover both left common carotid artery and the left subclavian artery. So if we do a open chest debranch, obviously it will be like a very high risk to have complications. And we don't know how long the fenestration, percutaneous fenestration would take. That's why we decided to do a bypass to the left subclavian artery. We don't want to spend too much time on the common carotid artery. That may cause a stroke, so you don't want to stop flow for too long. So we did a bypass from the right carotid to left carotid, and then we did a percutaneous fenestration of the left subclavian artery. This is all back, as you can see. And this patient was a little difficult, and then we use a balloon to push this graft when we puncture. And once we puncture and we pop the balloon, then you can see the contrast that kind of disappeared, and then we know we were in the true domain. And sequentially dilate same thing, and that's what we pull out. Show that you see this both common carotid artery and this left subclavian artery is well elevated. Okay, see, let's do a comparison. So the case on the left side was published on JBS a couple months ago from Japan, and one on the right is from us. You can see this circular aneurysm here is pretty much, similar location, better view with the 3D. You can see, it's, the relations with the branches is pretty much similar, okay? See what they did? That's what they did an open chest and retrograde bypass from ascending aorta to all the branches like this, and then covered this. And then that's what we did. So we did a small cut down to the left common carotid artery, put the stent in there, and puncture the brachial artery, did a penetrated left subclavian artery, put a covered stent in. So our patient went home in 2 days. So, and as you can imagine, the long-term tendency with this anatomy and this. So, okay, so the most recent study just published last month or 2 months ago, and showed in-situ left subclavian artery fenestration is reasonable and effective, and it can extend the proximal landing zone to help us seal this either aneurysm or dissection. Our experience is totally agree with that. In summary, left subclavian artery revascularization is recommended by the previous studies and the SCBS guideline, and the percutaneous fenestration is feasible and effective. It can be done with the common cath lab supplies, even if you do not have laser machine system, so you still can use off-back or off-road to do it. Then fenestration, we need a re-entry device, a cutting balloon, cover stent. That's our basic. So it's like I said, it's feasible and effective. Thank you.